Welcome back, everybody, to the Medical Biochemical Genetics Clinical Course Seminar Series. We are delighted this week to have Dr. Curtis Coughlin talking with us. It's September 1st, 2023, week 7. And happy September. Again, we're happy to have Dr. Coughlin talk with us about lysine and glycine metabolism. And as per usual, the CME credit will pop up in the chat for you guys to claim if you want to. Questions, if you have them, put them in the chat too, and Dr. Coughlin will get to them when he's able, either during the talk if he sees them or after the talk is finished. So with that, I don't have anything else to do for housekeeping. Curtis, do you want to get started?
Yeah, thank you, Pete. I just want to say that I am so delighted to be here. I love this series. I listen to all of these lectures every year. I learn something every single lecture every time, which maybe suggests that I'm not remembering things very well, but just really glad to be part of it. I don't have any disclosures, although I do want to admit that a lot of what I am going to say is based on things I've learned from just some amazing mentors in our field. I had the opportunity to train in Dr. Goodman's laboratory, so anything I say about GA1, I'm sure that Steve's voice is in my head, and you've probably heard him see it. Um, and especially, I'm going to talk a little bit about NKH, and my name is going to be on some of those papers, but this work is definitely driven by Johan van Hove, Dr. van Hove, just really probably the world expert on NKH. So hopefully you've had an opportunity to listen to the amino acid series 1 and 2 lectures by Nick Amu and Sean McCandless, just really great lectures on amino acid metabolism. They did a really great job talking about amino acid metabolism in general, as well as sort of focusing on a few diseases. So I am just going to give a much more focused clinical talk in this hour and a half, which means that some of you are going to love it and some of you are not, and that's okay. I think I barely show any amino acid structures, so I apologize for that in the beginning. Also, I'm trying my best to leave some time for questions at the end, so that maybe I can answer, or maybe all of these other experts who tend to join these talks can answer when I cannot. But I'm more than happy to answer questions as we go. So with that, talk a little bit about glycine metabolism. And so when we think about things that can cause elevated glycine in general, a lot of times we do think about defects within the enzymes of glycine or the glycine cleavage system. But there are certainly other genetic and non-genetic defects that cause an elevated glycine. So I tend to show things visually in a few different ways because I think we all learn differently. So here is a figure of glycine metabolism from a book chapter that Dr. Van Hove wrote with a couple of us, including I'm an author of this one. And here's a table for those of you who want something a little bit more concrete and table oriented. And so there can be defects in the enzyme that really metabolizes glycine, the glycine cleavage enzyme. This enzyme is actually encoded by 3 genes, although one of those genes, GCSH, has other functions as well. There can be cofactors that are required for the glycine cleavage system, and this is a growing list of disorders that sort of are involved in lipoate deficiency or synthesis. Um, Actually, there can be secondary defects of glycine cleavage system due to missing an important cofactor, parathiol 5-phosphate, which we'll talk a little bit about. You get secondary inhibition of this system by having organic aciduria or taking a medication, or occasionally, I think twice this year, I had emails from colleagues who noticed that their patients who were on IVIG and they got amino acids immediately after had an elevated glycine. So I think the point I'm making is that there can be a lot of reasons for an elevated glycine itself. Some of those are really important keys to a primary metabolic disorder, and sometimes it's just sort of a secondary finding. For most of the talk, of the glycine, I'm going to talk about primary glycine disorders. If you ask me, all of these other disorders really fall under the purview of another talk, and I bet will probably be discussed by other faculty members in this series. So NKH is actually a relatively common disorder, about 1 in 60,000 live births. And again, we already said that it's encoded by three primary genes, GLDC, AMT, and GCSH. It does result in elevated glycine, although that can sometimes be difficult to tease apart. And we're going to spend some time on the biochemistry, the genetics, and sort of the treatment for this disorder. First, I want to point out that elevated blood glycine is really non-specific, although this is a very old figure on this slide and not very high resolution. I love this paper because it looked at elevated plasma or blood glycine in children. This was based on a newborn screen approach of NKH and showed, and the little arrows at the bottom, if you can see them, are actually patients with NKH. And so you can certainly see that the NKH patients are much higher glycine levels over 600 micromolar, but there is a patient who has a much lower glycine level, and that there is a pretty significant distribution of glycine in the general population. The best way to diagnose NKH is through CSF glycine. Um, CSF is not always perfect either, as we can see. It really is dependent on how good of a tap that you have, on the age of the patient, to be honest, and very few times, in fact, just one or two that I can remember in the literature, patients with NKH can actually have a normal CSF glycine. In those patients, actually still the plasma glycine, CSF glycine ratio was helpful. So it is always recommended to get both of those at the same time. Here, again, just because everybody learns differently, here is another pathway that was published by Dr. Van Hoof's lab just last year. And one of the reasons why I really like this pathway for me is a reminder that, yes, glycine is elevated. It's immediately, it's very proximal to the glycine cleavage enzyme block here that you can see in red, but also that we should see some other changes in amino acids, mainly serine and threonine. So all of us love biochemistry, is my guess, is why you're on this call. Like we feel like um, what we see in our amino acid profiles or really help us sort of not only understand the disease, but make diagnosis in patients. But really the gold standard for those of us in biochemical genetics is we'd really love to be able to use this biochemistry and be able to say something about the severity of the disease or predict some prognosis. And so this is a nice paper by the Van Hove lab that was published last year. And you'll see that I add a lot of QR links for papers that I think might be interesting, and you can search these papers later. But really the goal of this was to say, can we predict the clinical outcome of patients with NKH based on the presence of any of these, either glycine, threonine, or serine? And a couple of CS biomarkers really do help to do that. You can see here in the top left that CSF glycine, in general, not a surprise to anyone on this call, that the higher your glycine is in CSF, the more likely you are to have a more severe phenotype. But man, there certainly is some significant overlap between the attenuated and the severe kids with this disease. And then we can sort of see the same thing for the CSF glycine and serine, which was really interesting in this paper, and it's a small number of patients, was that it really is helpful to get all of these biomarkers. So that's the biochemistry of NKH. Talk a little bit about the genotype. So this is a paper that we published, 6 years ago now, where we reviewed almost 600 patients with NKH and looked at sort of the genetic frequency of this disease, as well as tried to make some genotype-phenotype correlations. And in these patients, we sort of saw what was already in the literature, just a lot more patients, is that the majority of patients have mutations in the GLDC gene, that there were a significant number of patients who had copy number variation. In fact, a couple of patients who sort of were compound heterozygous for copy number variations. And at the time, we thought that that was really striking, that if someone had relied on more traditional genetic sequencing, they probably would have missed those patients who had compound non-overlapping copy number variations. Although I think that current genetic technologies probably would be able to identify those. And then a smaller subset of patients have AMT mutations. Those people in the audience who've seen a lot of NKH patients probably realize that there's also an ethnic distribution of GLDC versus AMT mutations, and that GLDC is much more common in the United States and in most of Europe. So it's probably why we see this distribution being so specific in our cohort. If you read older papers, you would see that we would always say that the glycine cleavage enzyme is encoded by all three genes: GLDC, AMT, GCSH. And then you'll see like this period in the literature where a group, including ours here in the Van Hove lab, and I was part of those papers, were like, oh, GCSH is actually not involved in the glycine cleavage enzyme. We've never seen a patient with a mutation in GCSH. It probably would have a much more distinct phenotype, probably wouldn't look anything like NKH at all. And so that, of course, was wrong. And this is a nice paper, a collaborative work from quite a few groups, and reported 6 patients with GCSH mutations. Those patients sort of have a large phenotypic spectrum that look, pretty similar to severe NKH, as well as, or more like PDH, or a combination of both. I think this was one of those nice things that reminded me that anytime that I am sure that I know something, that means I'm probably wrong, and I should just wait a few more years until we identify that patient who teaches us a lot more about biology. So GCSH encodes for genes and multiple enzymes, and something you should really think about as well when you see elevated glycine and they don't have a classic NKH phenotype. So what is the classic NKH phenotype? I think what most people think of is something like this patient who we have a video here from this nice paper in 2017, 2018. But I'm just going to give sort of my own experience seeing kids with NKH, and that is that really they can progress into sort of an apneic coma and ventilator support really, really pretty fast and in front of your eyes. I like anecdotal example, so apologies in advance for that. But I remember seeing a patient in our own ICU here in Colorado, where they got amino acid profile early, and there was elevated glycine, and the kid looked okay, and we went to see the kid in the NICU, and in front of our eyes sort of started to have some apnea and progressing into a coma really, really quickly. Sometimes these kids really don't have any other symptoms other than having this apneic coma, although many of the children have myoclonus or hypotonia as they progress. For the most part, kids with this classic phenotype make very little developmental progress. Their seizures usually increase over time, and we'll sort of talk about the strategies to improve their seizure frequency. Some things that maybe we don't think about as often because we think usually about presentation, but over time, almost all of the patients develop a pretty severe cortical blindness, and they can have some significant orthopedic involvement. I think for any metabolic condition, usually there is a spectrum between sort of this severe, this mild, and moderate phenotype, and that is true in NKH as well. Dr. Van Hove's group has really done their best to try to categorize these patients into what he calls a poor outcome, or sort of that like classic severe presentation, an intermediate group, and a better or a good group. And for the most part, this is sort of based on developmental testing we've done. So you'll see that we use developmental quotients, or IQs, a few times. But in general, the most poor end of the spectrum, those kids really have those early onset presentation most of the time, almost always have seizures, really have poor development. And on the other side of the spectrum, you can see kids that really just have a very hyperactive phenotype. Some of the most hyperactive kids I've ever seen in any genetic clinic. And so I can say those words, and I'm not sure how helpful that is. And I'm more of a visual learner. So here is a very nice movie, courtesy of Dr. Van Hove. And so you will see this girl in the front who, as you can guess, has a very mild or attenuated form of NKH. You can see that her unusual gait, but she does not have seizures, and she's interacting with two children who have very severe presentations of their diseases. One has classical NKH, and one actually has HCFC1 deficiency, which we'll mention in a moment. And then this boy who is, again, more attenuated. So you can see it's a pretty dramatic difference between this more severe phenotype that we see in the video and the more attenuated phenotype. We think a lot about how hard it is for all of us who see patients to be able to share that information with families at that neonatal diagnosis, to be able to predict, which of these, whether their child is that more severe end of the spectrum or the more attenuated form of this disorder. And Dr. Van Hove's lab has spent a lot of time trying to figure out what are the possible predictive markers of an attenuated phenotype. The best markers so far to date is really genotype. There are some very specific pathogenic variants that are associated with a mild phenotype. And so being able to get genomic results back very quickly in the NICU when a patient first presents is really critical. I think that is more and more common around the world and available to more people. At the time of this paper, this study that we did in 2015, it was a little more unusual to get genetic test results back quickly. Usually we would get results back past that time where children were in that period where they required ventilator support and where families were often considering withdrawing life-sustaining measures. And so we tried to find other things that might help a clinician think whether this child could have an attenuated or severe form of this disease. This is just one chart from that paper. If you see a kid in the NICU, it's a paper that I highly recommend looking through if you can determine whether or not this patient has a more mild form of the disorder. One thing I want to point out is this very first row, that the onset being later after 4 months is usually associated with an attenuated phenotype, but not always. And I think that's really important to mention that some of the very mildest kids can present at a few days of life. It's unusual, but it's possible. And some of the most severe kids can actually present outside of that typical first few days of life. Very unusual. Certainly, one of the things that the group was hoping for was that there could be some characteristic MRI finding that would help determine a more severe or mild phenotype, as MRIs are something that we can get pretty quickly. This is another nice paper that sort of showed the progression of MRI findings over time. A couple of things that came from this paper is that there really is a diagnostic findings in the MRI. And so if it's a patient you're unsure whether they have NKH or not, that the MRI can really be helpful to be like, this elevated glycine really is due to classical NKH. Although it's been harder to find something that's associated with more of that mild phenotype to differentiate the two. Also, something that was really interesting and important from this paper is that there really did seem to be some progression in this disease over time, which I think highlights the possibility that this is a progressive disease, and that maybe intervening in some way with some therapy early still has the opportunity to change the trajectory of this disorder. I think if you've only seen one or two patients with NKH in your career and you've seen the more severe side, I'm guessing it feels like what we do has minimal benefit to the patient. But this really suggests that maybe there is some window where we could intervene and improve these kids' lives. So how do we treat NKH? The goal right now is mainly to lower glycine. This is done in two different ways. Probably classically, we use benzoate, and Nick and you talked a lot about benzoate in the setting of urea cycle diseases in the amino acid 1 lecture. But as a reminder that benzoate binds glycine and converts it to hippurate. In urea cycle diseases, we're using this to remove the nitrogen. But here, we're just really trying to get rid of excess glycine. Some nice things about benzoate is it's really cheap. We have 30 to 40 years experience using it in urea cycle diseases so that we know that it is relatively safe. There is a very small risk of benzoate toxicity, so it's something that you have to monitor your glycine levels for, but in general, it's a pretty safe medication. Some downsides to it is that it tastes terrible if it's one of the NKH patients who still receive medications via mouth, although that's a little bit unusual. And certainly, I think it's a bigger issue for patients with urea cycle diseases who usually are taking things by mouth. Another way to lower glycine is through a ketogenic diet. One thing I will say is that it is really important if you're switching a patient from being on benzoate to benzoate plus a ketogenic diet, you're really going to have to lower or maybe even stop your benzoate, as the ketogenic diet is going to dramatically lower the amount of glycine. There's been a couple of case reports that suggest the ketogenic diet has been associated with sort of a better outcome in patients with NKH. One thing it does seem to do is also improve seizure activity. So maybe there are less seizure medications, and that in itself can improve quality of life. Just last year, Dr. Emily Strzalkowicz, who's at Seattle Children's, and Dr. Van Hove and a group published some recommendations on how you should start ketogenic diet in a patient with NKH. And so I always found these sort of like practical recommendations really helpful if you're doing it for the first or maybe only time. So if that happens to you in the future, I hope you look back for this paper or look through the lecture on just sort of recommendations on how to start the diet. The other medication we tend to use in patients with NKH is dextromethorphan. We know that glycine can overstimulate NMDA receptors, and dextromethorphan has been used for decades now in patients with NKH. I know that, again, if you've only ever seen one patient, and there's been a lot of controversy about whether these approaches, lowering glycine, the use of dextromethorphan, really does seem to change the outcome in this disease. It's a pretty severe disease, and these treatments also seem to make some difference. But the question is, would the child have been about the same or not? So I really love this paper, and I guess I'm biased because I am on this paper, but this is a great work by Kendra Bjorker, who is a neuropsychologist working with the Van Hove lab. But what they looked at is they looked at a couple sets of siblings affected with NKH to really see if there was a difference in those patients who sort of took a long while to receive the appropriate diagnosis or took some time before they were treated with an appropriate medication to benzoate to get glycine into sort of a therapeutic level, and the addition of dextromethorphan, and compared them to their second sibling who had the benefit of that family diagnosis, and treatment was really started almost after birth once the diagnosis was established. And what we saw was that there was improvement in either developmental quotient or IQ in all of those second siblings. What's hard to get from this paper is really seeing these kids together. And we invited these children to come to Colorado as we did the developmental quotient testing, and just being in the room with the siblings, seeing that second child who was diagnosed and treated early was night and day compared to their older sibling. I always think that anecdotal evidence is very poor science, but certainly sticks with us when we're making our clinical decisions. And just it was really a dramatic difference seeing those kids treated after birth early with these medications. Now, I'm not here to say that this is an amazing benefit. Honestly, we obviously are seeing that kids have, an IQ of 55 after being treated early. So certainly still much lower than the general population. One thing that really stuck out to me was the behavioral changes and how much better behaviorally those earlier treated siblings were. Some other treatments for NKH is, I mentioned in the third slide that the glycine cleavage enzyme requires paradoxal 5-phosphate. Somewhere between 40 and 200 enzymes require paradoxal phosphate. This is one of the many enzymes that do. There's been a few case reports of patients who seem to do better just by receiving paradoxal phosphate. We assume that it stabilizes the P protein, and it's been these mutations sort of in this paradoxal phosphate binding pocket. It is unclear if all of these mutations in this binding pocket really would benefit from paradoxal phosphate, and whether or not they could also benefit from some other sort of chaperone. I will admit that this is my very poor way of transitioning from glycine metabolism to lysine metabolism. So I feel bad for the poor transition. But here are all of the other known genetic defects in paradoxal phosphate or paradoxine metabolism, including a lysine metabolism defect we're about to talk about in a moment. And that also, some of these genetic disorders, like pyridoxine-dependent epilepsy, have actually been misdiagnosed as NKH, as that glycine cleavage enzyme really is dependent on paradoxal phosphate, as are so many enzymes. And so what we see in kids with pyridoxine-dependent epilepsy is that they often have very high levels of glycine before we start them on treatment. Like I said, poor transition. I apologize. I'm happy to take more questions about NKH either now or at the end of the talk. Again, I'm so lucky to have worked closely with Dr. Van Hove, and actually Dr. Baker has worked with Dr. Van Hove during his training and was worked on some of that lipoate metabolism. So also, if you have specific questions about NKH, if you ask me, I'm going to ask Dr. Van Hove. So certainly someone to reach out to at the end of this talk. So that I'm going to move on to lysine metabolism, something that I love more than anything that someone should love in the world of biochemistry. This is a picture of just lysine metabolism in general from a paper Dr. Gosby and I wrote recently. But what I'm trying to show here is that lysine metabolism is complicated. It happens in the cytoplasm, it happens in the peroxisome, it happens in the mitochondria. A couple of different amino acid pathways sort of converge from tryptophan into lysine. And we really still do not understand why there are these two separate pathways in lysine metabolism. I'm probably going to refer to these pathways by the name of their most prominent biomarker. So we'll often call this pathway that occurs in the cytoplasm and the peroxisome the pipicolate pathway, because pipicolate is the most significant biomarker in that pathway. And then we'll probably refer to the one that goes through the mitochondria as the saccharipine or saccharopine pathway, depending on where you are from. And only one of those two words is right, but I'm pronunciations is right, but I'm not going to judge you on this call. So pyridoxine-dependent epilepsy is a disorder of lysine metabolism. This is the disorder that my lab and that I spend most of my time on. So we're going to talk a little bit about it longer than we should. We think that this is a fairly common metabolic disorder at about 1 in 65,000 live births. So more common than glutaric aciduria if you're trying to look at how many patients you have in your clinic. And if you don't have patients with PDE, you have to wonder where they are. It is due to a deficiency of an enzyme involved in the lysine pathway that I'll show in a moment. It's only encoded by one gene, ALDH7A1, and you're going to see that we have referred to this disease in the literature a lot as PDE-ALDH7A1. I really appreciate those of you in the field of metabolism who've reached out to me to tell me that that's a stupid way to refer to this disease. I sort of agree with you, but we haven't come up with something better. So thank you for those comments. And that the treatment for this disease is supplementing with pyridoxine, which should not be a surprise to you. It's in the name, as well as treating with some things that are focused on the fact that this is a lysine metabolic disease. Let's first look a little bit at the pathway. So the AASA dehydrogenase is, again, a step in lysine metabolism. In this disease, we get some really pathognomonic elevations of AASA and its cyclic equivalent P6C. I'm actually going to show some structures in a few moments so you can really see that these really are the same molecule, just P6C is the cyclic of AASA. These are really in some sort of equilibrium. We also tend to see some elevations of pipiculic acid. This was actually the first biomarker for PDE identified by Barbara Pletko and was really in some beautiful work shown that this seizure disorder was actually a metabolic disorder by identifying pipiculic acid elevations in some kids' blood, urine, and CSF. Unfortunately, pipiculic acid is not always elevated in kids with PDE and can quickly normalize, especially if you're treating these patients. And so it's not the best or recommended biomarker when you're thinking about making the diagnosis. Maybe someone in the audience is thinking, why in the world does a lysine metabolism result in a deficiency of B6 and require daily B6? What happens is that as the P6C accumulates, it forms a chemical condensation reaction with pyridoxal 5-phosphate. And so you end up with a secondary deficiency of pyridoxal 5-phosphate. So for those of you in the audience who would like to see some structures to make a little bit more sense, this is what occurs. We see that as the P6C is elevated, it sort of sucks up or reacts with all of the pyridoxal 5-phosphate, and we end up with a secondary deficiency of the active vitamer of B6, pyridoxal phosphate. So yes, if you were to do a CSF tap on one of these kids, you're going to see low or almost no pyridoxal phosphate, depending on how much P6C there is. It actually forms these two molecules that we very scientifically refer to as complex A and complex B. We don't currently look for these as a diagnostic biomarker, although I've seen some preliminary data coming out that maybe that might change in the future, where you could also look for these sort of secondary biomarkers. I show these as very separate steps in the pathway, but these really are in a very rapid equilibrium. In our lab, we usually can shift where this is by changing the pH when we're just trying to sort of measure the amounts of these molecules as these metabolites. As a result, if you're sending testing to a specific lab and you're monitoring these levels in a patient with PDE, I think it's really important to sort of stick with that lab because they're going to shift these in one way or the other, or in some laboratory cases, like for example, here in the United States, Marzia Pasquale's lab at ARUP, they report this as a single value because these really are in such an equilibrium. So if you're trying to compare um, uh, amounts from different labs, it can be pretty difficult. The other thing about these two metabolites is that they are incredibly unstable at room temperature. Usually they degrade within a few hours to 24 hours. Um, if you are sending these as clinical samples for a diagnosis of a patient, you probably know that these have to be put on ice, drawn and put on ice immediately and shipped on dry ice, and that sometimes you've probably received comments from reference labs that they were unable to measure these because they weren't frozen quick enough. I will say that my lab spent the last decade trying to look for some new biomarkers for this disease, as has other labs around the world. And there are two recent biomarkers published, 6-oxypipicolate that was published by us in 2019, and then another biomarker referred to as 2-OPP that was published by the group in the Netherlands, led by Clara van Karnenbeek. Exciting things about these biomarkers is that they're really stable at room temperature, and that's exciting for a few reasons. That means if you are sending a clinical sample for diagnosis, which you can do in the US either now or very shortly to the University of Colorado or Children's Hospital Orange County, to Dr. Abdiner's lab. You don't need to make sure that the samples are drawn and frozen before they're shipped. And the other thing that's really is exciting is we think that these could be good biomarkers for newborn screening of this treatable disease in the future. Both of these metabolites, 6-oxypip and 2-OPP, are derivatives of P6C. So I said I would show some structures, just a minimum amount in this lecture for those of you who really do want to see where all of these things come from. There are 3 new biomarkers on PDE at some point of publication at the moment. So if I am lucky enough to ever be invited back, or you hear me give another talk about PDE, hopefully there'll be some more biomarkers on this slide. The real question is, does any of them help us predict outcome or response to treatment, or how well a family is compliant with treatment? I really don't have any of those answers right now, but love to have those discussions if you think you have an answer. So far, we have not seen any genotype-phenotype correlations in kids with PDE. In 2019, we published 185 consecutive patients who had sequencing of the ALDH7A1 gene. And really, we saw that the variants are all throughout the gene. We also tried to do some enzyme activity in a bacterial expression system, so not in this patient samples, but also didn't see any sort of correlation between enzyme activity and phenotype, which I think all of us who work in this field are always surprised when we hear things like that, right? We feel like obviously nonsense pathogenic variants that result in no enzyme activity should be more severe than kids with, hypomorphic alleles that have, fairly significant enzyme activity. And so I'm also surprised by that, suggesting that maybe in my suggestion is that every patient ends up sort of in the same place by the time they're a child without appropriate treatment. And some of those patients just sort of get to that poor outcome quicker. So talk a little bit about the phenotype of paradox-independent epilepsy. This is a video of a child with PDE, but this was originally described as a seizure disorder. It was described in the 1950s, but sorry, I was just checking if there was a question there. Described it in the 1950s in a patient who had neonatal onset seizures who incidentally got an IM dose of paradoxine and immediately stopped seizing. And I think that's what most people think of about this disease is a seizure disorder. So if you've ever heard me talk about this disease before, one of my big things is this is not primarily a seizure disorder, or not all the time. Um, in fact, you might not have neonatal seizures, although to be honest, most patients will have a seizure between day 1 and day 3 of life. Um, it was classically described as having like no response to anti-epileptics and only responding to B6. And it's not always true. Some kids actually have some pretty good response to anti-epileptics. And one of the things that's really important about this is that these patients have pretty significant intellectual disability or developmental delay despite seizure treatment. So I want to highlight those things a little bit more. First, that there really can be some late onset seizures. Here is just a couple of anecdotal evidence again of some patients who had really late first seizures. So think about the one all the way to the right. She had her very first seizure at 17 years of age. And what really drives me crazy is when people say that she presented with symptoms at 17 years because she had a lifelong history of developmental delay and intellectual disability. That I wonder if they knew that she had this primary metabolic disease and we were able to intervene early, if we still could have improved her overall clinical outcome, despite the fact that she has seizures. So in other words, it's not just a seizure disorder. I wonder if there are individuals out there who who have never had a seizure but have intellectual disability and were missing this treatable disorder. I do get some emails and phone calls from individuals who are picked up with just isolated intellectual disability on sort of exome or genome sequencing. But then when we look back, most of them have had at least 1 or 2 seizures. But something to think about, this isn't just a seizure disorder. Intellectual disability has always been part of this disease, going back to the very first case reported at CHOP in 1954. And you can see that patients sort of have an average IQ somewhere between 70 to up to 75 in our most recent paper, although I think this is a little better because we started to do some treatments. One thing I want to make really clear is that these early patients were defined as having PDE because they presented at birth with seizures and they immediately responded to B6. In other words, they are like the perfect situation where someone recognized that they might respond to B6, they were given the B6, and they stayed on it. So even these early cases, we're not talking about sort of untreated seizures, but we'll come back to that thought in a moment. For the treatment of PDE, I want to highlight this 2021-ish paper on consensus guidelines for the management of PDE. In general, this is like my summary slide, is that all patients should be treated with B6 regardless of what other treatment you are doing, and honestly, regardless of what their current seizure status is, and that all newborns and infants we recommend should be treated with some sort of lysine therapy, talk about in a moment, and that children and adults should also be offered these lysine-based therapies. So treatment with B6, we do recommend giving paradoxine over paradoxal phosphate. In that pathway slide, I showed that really what's happening is you are decreasing the active vitamer of paradoxal phosphate, and you could argue we should be treating kids with paradoxal phosphate, but paradoxine is really cheap. Most patients get it off of Amazon. It is pretty stable. It's not sensitive to light. And although there's a risk with overdosing paradoxine, mainly with neuropathy, that's at very high doses of paradoxine, and we usually don't use even half that dose in kids with PDE. Paradoxal phosphate, certainly these kids would respond to it, and there are a lot of other disorders where you also require paradoxal phosphate, and paradoxine is not helpful, so you could just argue, well, let's just treat everyone with paradoxal phosphate. But even small doses of paradoxal phosphate have an apparent risk of cirrhosis, some pretty significant cirrhosis in some patients. It's just also hard to get, more expensive for patients, and just very sensitive to temperature and light, just making it more difficult for families. So in general, pyridoxine is a lot easier and works really well in this disease. Um, in our natural history study, it's somewhere between 95 and 98% of patients who are treated with pyridoxine never have a seizure. Certainly breakthrough seizures are not that unexpected, especially with illness, but really it seems that pyridoxine is often enough to not require any other therapies for seizure management. There is a number of kids in our registry who are on another antiepileptic, usually because sort of the background of the EEG doesn't look perfect, but we're still unsure whether or not that's really necessary. So hopefully someone in this crowd is thinking, Curtis, you're still ridiculous. The intellectual disability really associated with disease really must be tied to the seizures. I don't know why people treat with anything else other than B6. And maybe you're right. We have very little evidence that it's not true, other than we think all metabolic diseases are the same, sort of our best evidence. But here's some evidence. This is actually on the left. It's just one of my favorite case series where this first patient presented with seizures at 4 hours of life, pretty common time, but wasn't diagnosed with a B6 responsive seizure disorder for 20 days, spent all 20 of those days in the hospital trying different antiepileptics. None of them worked, and finally treated with B6 at 20 days. Child number 2 was born. They were treated prenatally with B6. Mom was. They actually stopped B6 as it got close to birth. The child had their very first seizure at 3 hours, immediately put back on B6. So 1 seizure. And then the third child, where they were treated antenatally with B6 and just continued on B6 after delivery, never had a seizure, never had EEG evidence of PDE, and the diagnosis was based on the familial genetic results. And so despite this really disparate seizure history, 20 days of uncontrolled seizures to basically no seizures in the next 2 kids, they sort of uniformly had pretty poor full-scale IQ, all done around the same age. I think they were all done around the age of 10 and compared to an unaffected sibling. So just one family, but again, evidence that it's not really the seizures that are causing the intellectual disability. It's not the late diagnosis. We tried to extend this in a small paper on the right here. I'm showing a figure that just reminds me to talk about it. I know it's a sort of a complicated heat map. This was done by, led by Lara Singh and our PDE consortium. But we looked at 18 families that had multiple affected children. If you remember, I talked a little bit about Dr. Van Hove's study where he did this in NKH, and we sort of just did the same thing in PDE. And we really wanted to see if those second kids who had the benefit of being diagnosed early because of their sibling, if they were doing a lot better because almost all of them were treated antenatally with B6. Almost all of them had 0 seizures at all. A few of them sort of had that same thing where B6 was stopped and they had 1 seizure and then started again. And despite this early diagnosis, this early treatment, they were very similar to all of their siblings, again, suggesting that early treatment with B6 is just not enough it doesn't really impact the intellectual disability. One thing that really struck me when we were putting this study together is just doing the literature review and seeing the high number of kids who died with unknown etiology of seizures, only for that second or third kid in the family to be diagnosed with a treatable seizure disorder. And in fact, just seeing that number of kids who died from something that would have seizure-wise would have been so easy to treat. I'm going to talk about newborn screening briefly. Made me wonder if that shouldn't be the reason we do newborn screening for this condition itself, is that we could prevent this fatal encephalopathy from occurring. So we do recommend that all patients also receive a lysine reduction therapy. So again, this is a disorder of lysine metabolism. When you give B6, you are overcoming that secondary B6 deficiency. but you're really not impacting this chronic accumulation of AASA or its related metabolites that we've talked about. And so we've have a series, when we refer to lysine reduction therapies, what we're referring to is either some sort of dietary lysine uh, formula, and we are in the US often using formula approved for glutaric aciduria. In other parts of the world, if you're listening from other places, there are some PDE specific formulas, but they're not available here in the US at this moment. And the other thing that we have tried is using high dose arginine, lysine, arginine, and ornithine all use the same transporter in the gut into the mitochondria and across the blood-brain barrier. And so we have trialed using this high dose arginine in order to sort of limit the amount of lysine that gets transported. Um, at the time of these guidelines, there had been 18 case reports or case series of groups who tried one or both of these therapies. All 18 case reports sort of, or case series sort of said the same thing. Here's two from our group, published in 2012 and 2015. And they all showed that we got a lot of biochemical improvement. You know, we patients had a level of AASA, we intervened on their metabolism and their biochemistry improved, and it made us feel better. I sometimes don't know if that's all that we're doing, if we're just improving biochemistry and making us feel better. But what was good is that there was anecdotal evidence in all of the papers that the patients did well. And so here's some from our study. But in general, most of the patients had improved quality of life, had improved developmental outcomes. And that's why these 18 case reports in the consensus guidelines, we said that we recommend this treatment for everyone. But I'll be honest, many of us felt like, are we actually helping patients? None of us want to just make our labs look better. We really want to improve patients' lives, and we weren't always sure that we were doing that. So I'm really proud of the consortium's effort on this paper, where we really wanted to see, does this therapy actually do something important? And we chose IQ as an outcome marker. And I am more than willing to debate with any of you that IQ alone is really not a complete measure of what we're doing to help patients. And there are so many other things that we should be looking at IQ. But in this study, our outcome marker was IQ. And so this was an ambispective cohort. Patients were placed either in a cohort based on treatment at the time of developmental testing using pyridoxine only. So they were only treated with B6, or they were treated with B6 and some lysine reduction therapy, either a lysine restricted diet, high dose arginine, or both. We were not powered to separate those different lysine reduction interventions. So they were just sort of counted as one treatment. And our outcome marker was standardized developmental testing. I think we actually ended up using 12 different developmental tests based on sort of the age of the patient and the geographic region they were in. And these were patients from all over the world. Of course, we controlled for those variables that we both thought were significant and those that that statistically seem significant. So, for example, how long before that you were identified to have pyridoxine-dependent epilepsy and treated with pyridoxine, which ranged from 0 days or antenatally in many of our patients who had a family history to 10 years of life in our oldest patient. And after controlling for those variables, what we saw is that treatment with both B6 and lysine reduction therapy was associated with an increase of 7 IQ points with I'm listing the 95th confidence interval there on the slide. And what you're saying is, Curtis, that is not statistically significant. And I agree with you. And in fact, I guess I wasn't surprised that it wasn't significant because we really took all comers. My example in this data set, pulling one data point out, is that we did developmental testing in a 14-year-old who was on pyridoxine therapy her whole life until she was 13 and a half. She switched to pyridoxine plus lysine restricted therapy at 13 and a half, was on it for 6 months, and then had her developmental testing. And she was in our cohort of lysine reductive therapies. Now, I wish at this moment I could tell you how early you have to start treatment. I'm going to give you some evidence in the next slide, and how long you have to be on it. And I don't completely know, but I'm guessing that 13 years of being on a different therapy and being on this for 6 months probably isn't enough. So we had always intended to really look at the data of patients who were treated early in life with lysine reduction therapy. I don't think this audience, I'm going to have to make the pitch that you have to be treated early for your metabolic disease to show any difference. We had picked the cutoff of 6 months of age because there's a really nice paper from the group in Toronto that showed that only their patients with PDE treated with lysine reduction therapy in the first 6 months of life had a normal outcome, and that their patients after 6 months of life had some intellectual or developmental delay. So it was a nice paper. It seemed like a nice cutoff, and that's what we chose. If you had to ask my opinion, I'm guessing the earlier you treat, probably the better, and that there's nothing magical about 6 months. But when we re-looked at the data, looking at IQ between these two groups, you can see that just looking at IQ, there is a statistically significant improvement in IQ in those patients identified early and treated early. And when you controlled for all of those same variables, what we saw was on average an increase of 22 IQ points in those patients who were treated with both pyridoxine and lysine reduction therapy in the first 6 months of life. Now, this 22 points was still not similar to the general population. We saw a difference of 66 to 88. So still about 12 points below the general population, but we really saw a pretty difference. And this also helped that it fit with our anecdotal evidence. Those patients who we've seen diagnosed at birth and put on these therapies at birth really seem to be very similar to their siblings. Again, more anecdotal evidence, but here is a patient of ours who was lucky enough to be in Colorado when they were diagnosed and treated at 28 days with lysine reduction therapy, and is older and just doing really, really well. Her family sends me a video every year to tell me how old she is how long it's been since her last seizure. Okay. That's all, anything about PDE. One thing I am so grateful to work with so many people on PDE, especially Clara Van Carnbeek and Sid Gaspi on that first slide, and people in the US like Jose Abdiner's group and Nicole Luongo's group. But really, this is something that's interesting to me because it's in the lysine pathway, a pathway we know so well and was so well studied by my PhD mentor, Dr. Goodman. So some of this slides are actually from Dr. Goodman, GA1 slides. So GA1 is about 1 in 100,000 live births. There are places around the world where this incidence is much higher. It is due to the deficiency of the glutyl-CoA dehydrogenase enzyme, encoded by just one gene again, GCDH. And most of the time we're making this diagnosis based on some elevated biomarkers, usually by newborn screening. And we'll talk a little bit about the treatment and how important emergency management is and what that means, and just how that is so key to this disease, but how we're going to use a very similar diet that we sort of stole from this disease for our work in PDE. So here's that same pathway I showed you a moment ago, just to show you that GA1 is farther down in this lysine metabolism pathway. This is after tryptophan metabolism enters this pathway. So formulas that are used for GA1 are usually both low in lysine and tryptophan. And we have some elevated biomarkers here: glutaryl-CoA, glutaric acid, and 3-hydroxyglutaric acid. So I said most patients in the world, although not all, are diagnosed on newborn screening. Not everywhere in the world is newborn screening done, of course, and not every patient with GA1 actually has an abnormal newborn screen, depending on the population that you're looking at. It can be as low as only 90% of patients with GA1 have a positive newborn screen, up to some parts like the US where it's over 98% have patients with GA1 will have a positive newborn screen. We often are looking at glutaric acid and 3-hydroxyglutaric in urine organic acids to confirm this diagnosis if we're just talking about biochemistry, although a few labs will also offer like quantitative glutaric and 3-hydroxyglutaric in urine or blood. But genetic testing is actually really good for this disease. Older reports sort of suggest that there is a number of patients who have no mutations in GCDH, but have like clear-cut GA1, both have like some striatal injury and have abnormal biochemistry. So at least in the data in the Goodman lab, it's about 98% of patients we were able to see have 2 pathogenic variants, and this is pretty similar to other labs. There's a great paper from the group in Germany where it's about 99% of their patients have 2 mutations in GA1. That still means that sometimes there are patients that just have a single variant in a pathogenic variant in GCDH, and that makes it really, really hard to determine whether or not this patient really has GA1, especially if it's someone who's picked up on newborn screening. I think it's a little different when you have a patient with sort of classic striatal disease. And in those patients, we often are relying on enzyme activity, which can be done in quite a few labs around the world. There was 2 recent papers sort of looking at the genotype-phenotype correlations in GA1, and I'm going to have both of those listed in the next couple of slides. But here is a paper from the Netherlands where they listed all of the pathogenic variants that have been identified in their sort of cohort of labs that they collaborate with or in any of the popular databases. So if you're unsure whether your variant's ever been seen before, this is a really nice paper to sort of look at and see how often that variant has been identified. There is a genotype-phenotype correlation in this disease, but it's really a biochemical genotype-phenotype correlation. So you'll hear patients often referred to as high or low excretors, and there are certain pathogenic variants that we know are associated with a low excretor phenotype. And so people usually define that one of 2 ways. In most of the literature, especially led by the German group, they sort of have a cutoff of how much glutaric acid is in the urine, and whether or not, I actually don't remember. I think it's 100 micromole per liter, if I remember right, in the urine. And that if you have less than that, you're a low excretor. Again, I have admitted that I trained in Dr. Goodman's lab, and he didn't use that definition because he felt like it didn't control for how much lysine intake a patient had and whether they were catabolic or not. And so what he used was that in low excretors usually have more 3-hydroxyglutaric acid in their urine than glutaric acid. And this is pretty true of all of the low excretors, either of these definitions. A couple of things that are really interesting about this phenotype is that the phenotype is dominant, if that makes sense. Like just having one of these low excretor variants, it doesn't really matter what the variant is on the other allele, you will have this low excretor phenotype. And that these are the patients that often can have a false negative newborn screen. So in some parts of the world where these variants are really, really common, there is sometimes a second tier reflex of looking for the low excretor variants on newborn screen to try to increase the sensitivity of testing. In these, I said there was two recent papers looking at these genotype phenotype, and anyone who's interested in GA1, I highly recommend both these papers. One from the German group, which is the figure on the bottom, and one from the Netherlands, which is the figure on the top. And these are just two figures from that paper, but what they're showing is the correlation between the amount of enzyme activity and whether you have sort of that low excreter or high excreter phenotype. And maybe not surprising to you, maybe it is, but the low excreters are often associated with higher residual enzyme activity, but they can also have very, very low enzyme activity all the way down to 0. You can see that on both of these studies. And I again want to emphasize that this is mainly genotype phenotype correlation for this biochemical finding. There is no genotype phenotype correlation for the risk of striatal necrosis, which is one of the main phenotypes we're about to talk about in a second. In fact, there's some really nice work done by, again, the group led by Stefan Kolker and Nicholas Boy that shows if you have a low excreter phenotype, you're slightly more likely, although I don't think it's statistically significant, to have a striatal event. And so that's really interesting to think about the reason for it. Is it because there's something innate about having the low excreter phenotype that gives you that slightly higher increased risk, or is it something that we're doing as the medical team, thinking, oh, maybe the biochemistry is not as severe, so we're not being as cautious with this patient? I really want to emphasize this again. There is no genotype phenotype correlation for risk of metabolic stroke, brain injury, striatal disease. Like this is every patient, regardless of their biochemistry or their enzyme activity, we should be on the same alert for. So the natural history of GA1, in previous, like before we had newborn screening for this disease, about 90 to 95%, depending on which paper you read, of patients who were undiagnosed ended up with a striatal injury in the first few months up to 6 years of life. Really interesting to think about why those 10% of patients escape this injury, because it is often occurs with some sort of minor infectious illness. I think most of us get really worried about patients when they have a fever, even really a small fever or any evidence of infection. But some patients just have really no evidence of that infection whatsoever. They have no event that you can point to and be like, oh, they were kind of sick. And we refer to this as an insidious onset. It's really interesting to think about why about 10% of individuals escaped having any injury whatsoever. In 1979, Dr. Goodman suggested that the risk of injury for a striatal event was about 6 months to 2 years. In conversations with him, I would ask him what the data was for that, and he went, I don't know, it seems that was the window, which is really shocking because I think he was pretty right. And so we often talk about the risk of striatal event up until 6 years, because that's the oldest a patient has ever had a re-injury, so had already had a striatal hit and had sort of secondary striatal damage, was just before 6 years of age. Although, as far as I'm aware, no patient has had that initial striatal injury after the age of 3. So that initial window really might be very true. But you'll hear a lot of people discuss whether or not treatment should be different before age 6 and after age 6. And that is, again, because there's nobody that we know of that has had a striatal injury, a primary striatal injury after 6. I don't know if Arig is on this call, but I believe she has a patient that might have had an injury after 6, although as far as I know, that isn't published yet. So maybe the next time someone gives this talk, they're going to say that is not true. So newborn screening has really dramatically improved the outcome in this disease. We sort of switched that now about where 90% of patients had a striatal injury and 10% didn't. Now it's 70 to 80% of patients have no striatal injury and 20 to 30% do. I think this number is really important for us to remember that this is still not great. There's still a lot of improvement here to make a difference in these kids' lives. 30% sounds crazy high, and there has to be something that we can do. There is some evidence that this could be associated with adherence to treatment we're about to talk about. I'm going to get on my one little soapbox here and say that I hate the idea that this is the family's fault. I'm not always sure that it's true that it's adherence, but even if it is, if that many patients are struggling to follow our recommendations, then we have to admit that this treatment is poor and we need to come up with other ways to help families. So you can see there's some really classic brain imaging findings and really helpful for diagnosing this disease. Again, there is no brain imaging finding associated with sort of risk of striatal injury in the first 6 months of life. I already mentioned that about 20% of patients have what we refer to as this insidious onset, where there isn't this clear-cut illness. There isn't this moment where a patient should have called you and said, or a family should have called you and said, my daughter, has a fever and isn't eating well, that they just had this onset of injury without a clear illness. There might be some evidence of sort of other secondary disease sequelae based on whether or not their striatal event comes from this insidious onset or an illness. I talked about the high and low excretors and that there's really no difference for that striatal disease, but this GA1 is more than just that severe striatal injury. In this nice work by the German group again, what they showed was that the high excretors might have a higher risk of subdural hematomas, and that there might also be a difference in IQ. I was really surprised by both of these papers, but here's the data and here is the figure for the IQ. You can see that there is some significant overlap for them, and they're both pretty low numbers. But what I love is that we're, as a field, moving away from sort of this like binomial description of this disease. You had a striatal injury and you're like have difficulty ambulating, versus like all the other impacts this disease can have and how we can really improve patients' quality of lives overall. I mentioned our PDE consensus guidelines recently. I really am a big fan of consensus guidelines, and I think I really love the GA1 ones. They were updated in 2022, although the reference is 2023 because that's when they were published in JIMD, and I believe this was the 4th version of their treatment guidelines. This is really an international group of experts led by the group in Germany, who are probably the most active in studying GA1. Number one recommendation is that emergency treatment should be started immediately at the sign of any febrile illness or any alarming symptom, or anytime a parent calls you and says, Jane looks like she's a little different than usual. And here is a nice study from that same group in 2021 that showed the risk of striatal injury based on sort of the delay in treatment of any illness. And not surprisingly, the longer that there was a delay, the more likely there was for a patient to end up with this life-altering metabolic stroke. Also recommended that there should be lifelong carnitine. This isn't necessarily just based on carnitine levels. I also was at CHOP for a while, so I'm a big fan of Charlie Stanley, who always used to remind me that the carnitine levels we see in blood are just sort of a small subset of all of the carnitine levels in the body. So it's not just that the carnitine level should be normal, but we are trying to use carnitine to sort of suck up all of the potentially toxic metabolites that we're generating. One of the big changes in this guidelines from the previous is sort of this idea of dietary treatment in this disease and how that it is slightly different before age 6 and after age 6. And I will say that this has been sort of an evolving recommendation over the last 3 sets of guidelines. So this is the newest one. We are again using that cutoff at age 6 because we think that the life-altering risk of a brain injury, that metabolic stroke happens before the age of 6. So in this higher risk time, the recommendation is really to use a lysine-free, tryptophan-reduced, and arginine-enriched formula. And then after age 6, that the diet changes, and you're going to hear people like talk about reducing the diet, relaxing the diet. Some clinics will stop a diet, but the recommendations is that a diet should continue but no longer be based on those lysine-free formulas, but should really be focused on sort of a protein controlled diet, making sure that patients are not getting too much lysine, and based on those recommendations should continue for life. You're going to notice that both the recommendations for PDE and GA1 recommend using arginine. I actually think both of them are based on this really good paper that was done that showed in mouse brains that the only time we actually lowered 3-hydroxyglutaric acid was when those mice were on a low lysine chow and a highly enriched arginine that sort of competed with lysine transport, and it made the biochemistry better. It's not great evidence. There were 2 clinical papers that showed that patients with GA1 that were on arginine-enriched formulas did well. We have a couple of articles on PDE that showed that patients do better on arginine. I'm happy to share any of those papers and data that we have with those of you who are skeptical, because I think all of us remain a little skeptical, but the recommendations for both diseases are to have some arginine involved in those treatments. Again, I said that they're about 30% of patients, 20 to 30%, depending on which article you read. And I've actually seen some data not published that might be even higher than 30, of patients identified newborn screen still have some neurologic disease. In other words, we still have a long ways to go in making this better. And here's a paper that suggests that the less adherent patients are to treatment, the more likely they are to have neurologic symptoms. Just again, my one soapbox is making sure that we are empowering those patients. What are the non-medical determinants of health that we're not addressing in patients that they're not adherent? Is it really adherence? Are we making ourselves feel better that we didn't do a poor job? And what else can we do to sort of make this treatment better for patients? There are new treatments coming out. I know I'm about to end on just like some highlights. These are not things that you can use clinically, but just really important things to think about. So again, for PDE and GA1, they're both involved in lysine metabolism. And a whole lot of groups have thought about using some inhibition of this first step in lysine metabolism to sort of limit the accumulation of all of these metabolites. So if you are under the belief that these diseases are caused by the accumulation of some neurotoxic compound, which could be AASA and PDE and 3-hydroxyglutaric acid and GA1, that inhibiting this pathway in general will result in a whole lot of lysine, hyperlysinemia, which we know some patients have and seem to be completely normal, and might improve all of the symptoms in this disease. And so there are, at my last count, somewhere around 10 groups who are looking at this therapeutic approach. Here's some recent papers. This is work led by Sander Hooten out in New York, here in the United States. and he made a double knockout mouse of that first step of lysine metabolism, AASS, and a GA1 knockout mouse. And if you look at these figures on the top, which is the plasma levels of, for example, 3-hydroxyglutaric acid, which most of us think is the most important biochemical metabolite here, in both plasma and brain, we can see that the double knockouts have less than the GA1 knockout, suggesting that, if you knock out that pathway, if you inhibit that pathway, you're going to improve the biochemistry. So that's a really nice example that this could work. And then there is a really great paper. If you haven't read this, I highly recommend it, from earlier this year, where the group at Duke, led by Mercedes Bazis and Dimi Bisic at Duke, showed that they could rescue the survival of GA1 GCDH knockout mouse. They did this in a couple of ways. First, they transplanted a GA1 knockout mouse. So this is that first figure here that I'm showing, and showed that simply by transplanting the liver, they were able to rescue the death of these mice. Really, they were doing this to show that focusing on the liver for this neurologic condition might actually have some benefit. There is an older paper on transplant in mice that shows some differences, that if anyone's curious why it's different, that group would happy to discuss it with you, and so would I. And then more interestingly, in that paper, they took a couple of approaches to knocking out AASS. They did the same thing as Dr. Hooten's group did, where they made a double knockout mouse, and which is the figure on the bottom, and you can see that it rescued survival of the mouse. The GA1 mouse here in figure A is the red, and the blue is the double knockout. So the AASS rescued survival, as well as you can see the biochemistry, again, the blue being that double knockout. And then data that I didn't show, but is shown very well in this paper, they used a liver-targeted CRISPR to knock out AASS in this mouse, and also was able to do the same thing. Basically, the biochemistry looks better, and so does survival. There is a very large consortium that hopefully everyone is familiar with, and I'm lucky to be a member of, called the Charlie Consortium, that is just focused on developing new therapies for PDE and GA1. So this is the link to the website, trying to not be so biased and show data I'm associated with, but also the same sort of data that Dr. Bisic and Dr. Hooten have shown, where this group is trying to target AASS through a number of different mechanisms, as well as gene therapy for GA1 so far. So a couple of really nice papers that are also linked on this. And what's exciting is that we're really able to cure mice of both of these diseases. And so the question is whether or not any of these will translate into our patients is still to be answered, but exciting that we're able to make a difference and hopefully have a therapy that will be more beneficial for patients. But that, I was going to end. My only other thing was to say that if you really want to hear from a true expert on PDE and GA1, I really highly encourage you to come to the OAA family meeting and talk to families with these diseases, which will be in Pittsburgh in the last weekend of June, and I'd love to see you there. And with that, I'm happy to answer any questions if anyone has any.
Great talk, Curtis. Thank you. Questions for Dr. Coughlin? It was quite thorough.
Well, thank you all for having me. It was really fun to talk about these disorders.
Thank you very much, Curtis. Coming up next week, we have Dr. Al-Garbawi, who's going to be coming on to talk about glycogen storage disorders. If you have any questions lingering for Curtis or want to get a hold of him about things he talked about today, his email is available. I can help you find it if you can't find it yourself. So thank you very much. Have a great, safe Labor Day weekend. And yeah, bye. Thank you. Thanks, Curtis.
Thank you, Oxy. It was a wonderful talk. Thank you so much.
Bye, Mary.